industry. We love these events, hosting these events for you so you can get really good, solid, trustworthy information. It is absolutely lovely to have all of you join us for another virtual empowerment event. This is an extension of the White Dress Project's Empowerment Weekend that we had actually last month. And the whole idea is part of the organization's commitment to supporting and empowering those living with fibroids. So great to have you here with us. Tonight's event is called Let's Heal Together, the latest in fibroid treatments. If you have questions, be sure to drop those in the chat right there to the right of your screen. We'll also drop the panelists' social media usernames in there for you as well, because they are always offering free, good, solid information and advice on social media. So definitely want to be sure that you are following them. All right, let's introduce you to the panelists for tonight. Dr. Rochelle Wolfe is an interventional radiologist, and she serves as the co-director of the research committee for the White Dress Project. And her mission in working with the White Dress Project is to track and present ongoing and emerging research related to uterine fibroids in terms all women can relate to and understand. Now, to help identify areas where research is lacking that has a direct and practical impact on women suffering with fibroids is also key to her mission as well. She is a board-certified interventional radiologist and the co-founder of the Vascular and Interventional Experts in Minneapolis, Minnesota. She specializes in uterine fibroid embolization, UFE, that is a non-surgical treatment option for uterine fibroids. We also have with us tonight Dr. Soyini Hawkins. She is an OBGYN. She is a board-certified, fellowship-trained, minimally invasive gynecologic surgeon. She has a strong interest in laparoscopic surgery and provides specialized surgical management of abnormal uterine bleeding, pelvic pain, and most benign gynecologic conditions. With a genuine passion for the physical, emotional, and overall health and well-being of women, Dr. Hawkins has dedicated herself to caring for the whole person by creating and partnering a relationship with her patients. Her skill set and her style allows her and the patients to become proactive partners in their health care. Dr. Brooke Winner is an OBGYN. She is a fellowship-trained, board-certified, minimally invasive gynecologic surgeon and the medical director for the gynecologic surgery at Swedish Medical Center. She performs a very high volume of laparoscopic hysterectomy, laparoscopic myomectomy, laparoscopic ovarian cystectomy, and laparoscopic excision of endometriosis. Now, most of her patients are actually referred to her by general OBGYNs for surgeries that they have deemed too difficult. Those are the ones that she takes on. Dr. Winner is able to offer a minimally invasive approach to almost every woman, including those with extremely large fibroids, stage 4 endometriosis, including bowel endometriosis, and patients with known or suspected adhesions. She is passionate about patient care, and she loves to educate her patients about their diagnosis as well as their options. Dr. Katashia Kendrick is a board-certified clinical pharmacy specialist, integrative health practitioner, health and wellness coach, infertility survivor, and advocate, speaker, and author, the ultimate multi-hyphenate. While working as a licensed pharmacist and dealing with irritable bowel syndrome, with constipation and infertility, she became frustrated with the lack of help from conventional doctors beyond prescribed pills every single day. So I do want to let her tell her own story because it's a really powerful one, but I'll just say that the journey led her to discover a passion for integrative health and functional medicine, and she received her certification to become an integrative health practitioner. She is now the founder and CEO of Celebrate Health and Wellness Coaching, LLC. It's an online company that provides integrative health and functional medicine services and health and wellness coaching for busy professional women. So you all have quite the panel here with us tonight. You're going to get top-notch advice. Can't wait to really dive in. I do want to start with you, Dr. Katashia, and just share your story because you're here on both sides of the aisle as a patient who's endured quite an amazing fibroid journey, but also as someone who's been on the other side and has looked into different types of treatments and medication options. So I'll let you start.
Well, good evening, everyone, and thank you so much for having me. I will start with my fibroid journey. It started back in 2002, where I was in pharmacy school, actually, and I was having issues with heavy bleeding periods and I just didn't know what was going on. And I was in New Orleans and I actually traveled home to see my provider to see what was going on. And that's when she told me I had fibroids. I had no idea what was going on, what my treatment options were. I just knew I wanted to feel better because I was in so much pain. The bleeding was out of control. I was living pretty much with a bag in my car all the time. I just didn't know what was going on. And so we decided to do an open myomectomy. And I had that in 2002. And at that time, no one, not even my doctor, told me that fibroids can grow back. So I thought I was fixed. I was fixed and I was living my life. And 10 years later is when I discovered that my fibroids were back. And at that time in 2002, she removed about 20 fibroids. Some were as small as little peas and as big as cantaloupes. But 10 years later, they grew back and they were pretty bad because at this point I had issues with, getting my hemoglobin was low and I was having issues with, fainting, all those things. And that's when I went back and that's when I realized that they were back and they were bad. They were back with a vengeance and decided to do a second myomectomy because I met the love of my life. We talked about having children and I was really trying to save, my fertility. And at that time in 2012, that's when I was diagnosed having stage 3 endometriosis as well. So all the pain that I was having and, distended stomach, that's when I learned about that and went through that surgery. And within a year or two, my fibroids were back. And at this time, it was the worst pain ever. I wasn't able to sleep at night. When I tell you that I had no idea they would grow back so fast in 2 years. And I really just put it all in a bubble and didn't want to deal with it. So I started just really enjoying life, got married, and we were trying to get pregnant. And every month, a part of me died because I kept getting my cycle. And sometimes the cycles wouldn't even stop. And that's when we went in. And that's when my doctor told me, I actually went to another doctor. And I always advocate to, if you need to change doctors, it's okay to change providers. And that's when my provider told me, I really can't tell you exactly what's going on in here until we open you up. And this is really a small part of the story, but just know that my surgery ended up being almost 12 hours because my organs, according to my provider, literally were pushed up into my chest because the pain, I was sleeping on the floor. I just couldn't get any relief. And she told me that I had, my endo, of course, back. I believe it was stage 3 again. And she said she couldn't find my organs because of all the fibroids and endo that was ever on my rectum, on my bladder. And so she literally told my husband that she had to pick out my organs to make sure she didn't take them out because of everything that she was looking at. And in 2016, I actually had a hysterectomy. So, which was really devastating because that my dreams of being a mom at that time, it went away. Went through that process and here we are. I'm much better. I'm feeling better. I'm so happy and at peace with the decision. But here in 2022, I learned that I have stage 3 endometriosis because I didn't get my ovaries taken out because after the hysterectomy, we were looking to do surrogacy and that did not work out the way we wanted to. And so actually I'm planning to have surgery at the end of this year because the pain and all the things that I've been experiencing now for 20 years is back. And so at this time, this is it for me. I'm going to go in and I decided to go ahead and have my ovaries removed. And I'll be doing it in November. So that's my story.
This is the second or third time I think I've heard your story. And every time I'm always amazed at how at peace you are with everything. And I know this is not a treatment option question, but I do want to ask for anyone else who's going through this journey, how did you get here emotionally and mentally, being at peace with these decisions and things that are outside of your control?
It took some time. I won't sit here and say, oh, it just happened overnight. And I prayed. And there are some times that, you get tired of praying, like, Lord, help me. But I realized going through the first couple of surgeries, I didn't have a therapist involved. Yes, I went to church. I had my support group, but now with my last surgery and going into this my very last surgery, I realized how important talking to someone outside of family truly is, because a part of me died. I feel like grieving. I didn't take time to just talk to someone outside of my family and church, but being able to find a really good therapist to be able to talk, with and get through this process. And honestly, my village, my mom and my husband most definitely were there for me, but to be able to get through this process without them, of course, the Lord, I couldn't imagine, but I most definitely would recommend getting someone outside of that village, because that therapist of mine is awesome. So getting through that with him now is one of the number one things I would recommend for anyone.
Yeah, I appreciate you saying that, because I know, especially in the Black community, we have this thing with therapy and mental illness and mental health, and we just put up a wall. And I think it's so important. We should take good care of our physical health. We know to do that, but our mental health is something that, especially in this community, we let wane. I want some of the other doctors to kind of weigh in here. I know, Dr. Katashia, your case was, I don't know if the word extreme is the right word, but it was pretty serious. We can go with that. I'd like for the other doctors to weigh in here. And I know this is 20 years ago and treatments have changed, but Dr. Hawkins, listening to her story and listening to all of the surgeries and treatments that she endured, my first question is, why can we not crack this fibroid thing? I mean, to her point, you have the surgery and you think, done. And here they are again. And then here they are again. Why haven't we been able to crack this case?
Yeah, I wish I had an easy answer for that. I wish I had a, perfectly put together explanation as to why we don't have more answers than we have. We need more research. I mean, we've all heard it. We need more research. We need more funding. We need more people to tell their stories. Thank you so much, Dr. Kendrick, for sharing and being so transparent, because you will help women, even with the understanding and acknowledgement that fibroids can recur. I hate that your doctor wasn't able to share that with you or educate you enough for even just vigilance, right, of the symptomatology, because maybe even with the second occurrence, you had a 10-year span of time. The symptomatology may have started even earlier, and a lot of times the options change as we go further in our disease process, right? So that acknowledgement that this is something that, now that I know I have fibroids and endometriosis, my vigilance of that and the understanding that these potentially are chronic conditions that, maybe surveillance and maybe when my symptoms start to appear, I seek a specialist like myself and Dr. Winner that can jump on it and offer options sooner. And I agree, things have changed. Thank God we have become more advanced in our technology. We have many more options than we did. I had open myomectomy 12 years ago, and some of the options that are here now weren't there. I had an open myomectomy just the same. And now my fibroids are back. And this time around, I know I have more options than I did 11 years ago. But thank you so much for your transparency. I wish I had an easy way to answer that question.
Dr. Wolfe, I know you're, the research queen, especially in this topic. And I often wonder, we hear a lot of women say that they have uterine fibroids and endo and something else. Is there a connection between all of these chronic issues?
So again, the research is a little bit lacking, but some of the more recent papers, as recent as 2022, do show that kind of chronic pro-inflammatory states can be linked to endometriosis, to fibroids. Fibroids, there's a strong linkage to vitamin D deficiency. We know there's a strong prevalence in the Black community of vitamin D. So I think as research comes out more and we start to see these correlations, that we can take some more proactive preventative measures of getting ahead of it. So, there's a study that just came out that post myomectomy, giving, 1,000 units of vitamin D for the year post myomectomy, that recurrence rates and size of residual fibroids were decreased. So again, it's trying to look at some of these papers coming out, looking at all the research, because when we look at it, I get stuff coming in every week. If you type in fibroids, you get over, 20,000 search results. So it is being done. It's trying to get those, double-blinded randomized control trials. That is somewhat lacking. And the difficulty with research in fibroids is fibroids present uniquely in every woman. So you can't take one woman with this type of fibroid, this woman with, 10 fibroids, and look at how they present, because it really does present uniquely in each individual woman.
Interesting. Okay, Dr. Winter, I want to bring you in here. As someone who has extensive experience in minimally invasive surgeries for gynecologic issues, listening to Dr. Katashia's story, what's your take? And again, I know this is 20 years ago, but your take now, would things have been different?
Yeah, so I think one important thing to recognize is that the risk of fibroid recurrence probably has to do with how many fibroids you have in the first place. So I tell patients that if you just have one fibroid and I take it out, it's only a 20% risk of recurrence. But if you have 5 or more fibroids, which you certainly did, you have up to an 80% risk of recurrence. So that really matters in terms of the counseling. I agree with Dr. Hawkins that, I always talk to patients about the risk of recurrence and when they should get another ultrasound. I don't recommend a routine yearly ultrasound, but I tell people to have a very low threshold if they have any irregular or heavy bleeding or pelvic pain, pressure, urinary frequency, all those bulk symptoms, or if their regular OBGYN feels like their uterus is enlarged on their once a year exam. Those would all be reasons to check another scan. In terms of the fertility piece, I listening to your story, I was wondering, were you working with a fertility specialist? So in somebody like you, I would go in there, I would take out every single fibroid that I could see or feel. I would do it minimally invasively, which decreases adhesive risk. And then if you didn't have any other causes for infertility, I would say, try to get pregnant for 3 to 6 months. If you get pregnant on your own, great. If not, then go see a fertility specialist. And, you kind of had the double whammy with the endometriosis and the fibroids that can complicate things. So yeah, it's easy to, in retrospect, think if things could have been different, but a lot of this wasn't available 20 years ago.
Exactly. We do have a couple of questions I want to get to right now. A question from Ardella Jeffries for Dr. Kendrick. Did you have excision surgery for the endo or ablation?
Excision, and that was going to be the plan for this year as well. It was the best option with the options, the treatment plan, I guess the treatment options I had at the time, but excision, and that's exactly what's going to happen in November when I do it again.
We also have another Wendy Payne has a question. She says, I was told fibroids go away when you hit menopause. So she said she waited and she still looks like she's about to give birth and she's 60 years old. And then she said she hit menopause years ago and she still has the fibroids. What is your all take on menopause and fibroids? I think that we all understand fibroids happen in women of childbearing age who have estrogen, which is everybody. But what's the deal with menopause?
They shrink by 1/3 to half, so they don't go away entirely. For some people, that's enough. For other people, it's not enough, especially if the fibroids are really big to start. You shouldn't develop new fibroids in menopause. So if you're menopausal and you're developing new fibroids, that raises some flags for maybe there's something else worse going on.
Okay, Dr. Winter, you have dropped 2 gems on me tonight because I had no idea that the number of fibroids affects or impacts the, percentage, the rate of recurrence. I've never been told that. I knew that they could recur, but that percentage was pretty interesting. And I was also under the impression that in menopause, your fibroids pretty much go away. So interesting to know that they minimally shrink. Okay, another question. If you have fibroids and endo, should you also get an MRI as well as transvaginal and abdominal ultrasounds? Does that just depend on how much you guys want to see before going into surgery? Dr. Hawkins, I'll let you take that one.
Correct. Exactly. A lot of times it depends on the symptomatology, and sometimes it's not just that. Sometimes we want an MRI. Sometimes we want you to see a GI specialist and get a colonoscopy. A lot of it depends on how that presentation is when the patient comes to talk about their surgical or intervention options. I do get a lot of MRIs from our patients with fibroids, especially if there is a question about where their pain might be coming from. But of course, we all understand with endometriosis too, you can't always see it with imaging. Usually it's when I'm concerned that there might be a more severe state. Maybe I'll see tethering or what was called pulling of the rectum on the lower portion of the uterus. And that usually gives me a clue that there could be some more severity to their endometriosis. So not every patient is going to receive the same recommendation. So it's not, unfortunately not quite cookie cutter, but talk to your doctor about it if you have those concerns.
Yeah, and I can share my personal story. I saw a fertility specialist, and Dr. Winter, you brought that up. That was, I went from an OBGYN to a fertility specialist and then to someone who could take the fibroids out. And I also, my doctor who did the surgery, she said, yes, I have the ultrasound, but I really want to see what's going on. She got the MRI, but I had an open myomectomy. And when she went in there, the MRI showed 6 fibroids and she took out 10. So even with the MRI, you didn't get the full picture. Dr. Wolfe, I want to ask you about UFE. It's something that a lot of people have questions about, because I think in terms of removing fibroids or shrinking fibroids, treating fibroids, I'll say it is the least invasive. You're not cutting anyone open. But I also am always curious, are there limitations in terms of where the fibroids are, whether they're pedunculated or not? Is UFE something that can be used on large fibroids, small fibroids? Are there any limitations?
So it's interesting because uterine fibroid embolization has been around for over 20 years. So throughout the span of my career, I've seen changes in recommendations. What we've found out over time is really there isn't any limitations. It used to be probably over a decade ago, we'd say, if it really was over 10 centimeters in size, may not be a good candidate. There used to be some concerns if it was a pedunculated fibroid. But what we find out is regardless of size, number, and location, really about 90% of women, particularly women who present with heavy menstrual bleeding, will get a near complete resolution or resolution of their symptoms, so their periods go back to normal. I've had, in my career, even I've come across some women for either religious or other reasons, I'm saying, well, maybe you should actually go have a myomectomy, you should have a hysterectomy. And I actually push them. I've seen people whose aorta has been pushed to the opposite side of their body, their liver and their kidneys pushed up. And I was like, in general, we shrink at least 50% in volume of fibroids with our treatment. And I was like, again, if you're presenting with bulk symptoms, I don't know how much people are going to respond, but yet I get amazed that we do this treatment. And even at about the 2-week mark, women who come in with severe, getting up 2 to 3 times at night to urinate, bladder symptoms tend to improve, rapidly. So what I've learned is not only do they shrink, but they also soften. And it's typically that combination. And with the fibroids growing typically slowly over time, the body accommodates. So even some of that, 50% reduction in symptoms is a significant reduction for most women that they do get symptomatic improvement.
I want you to briefly just explain to people how UFE works, because I know it can be a little bit confusing. And then I'll also ask you how it impacts fertility, if it does.
Right. That's going to be a harder question. So uterine fibroid embolization, it's typically nowadays, most places, it's performed as an outpatient. Should take an hour or less. We perform it through a 2 to 3 millimeter nick in the skin. We either can go into the artery by the groin, called the femoral artery, or we can go into the artery by the wrist and get there. And essentially we find the arteries that supply the uterus and fibroids, and we inject tiny little particles that are basically estimated to the size of the blood vessels supplying the fibroids. So over time, we know that size of particles. And what I tell my patients, it's a thing of physics. Those particles go in with blood flow. So fibroids tend to have bigger blood vessels and more blood flow than the rest of the uterus. So we kind of prune the tree to cut off the blood supply and hence the nutrients to the fibroids. So over time, they shrink and die. So, it's not a magic eraser. I'm not cutting anything out. I'm not taking anything out. But in general, they shrink about 50% or more in volume. Women are able to go home the same day. The worst night, first night tends to be the most difficult from a recovery, just with menstrual cramping. By day 3, women are feeling pretty good. And usually by about day 7, people are back to their normal activities. So very simple outpatient procedure. You go home with a Band-Aid, essentially. Fertility. So same thing, over time, there hasn't been any head-to-head trials looking at fertility post uterine fibroid embolization versus myomectomy. So again, there's, looking at all of the studies out there, what I counsel in the most simplistic terms is, can you get pregnant after fibroid embolization? Are you guaranteed? No. Can you get, pregnant after myomectomy? Yes. Are you guaranteed? No. And it really depends on size, number, and location. Like if you have one submucosal fibroid, intramural, even transmural fibroid, probably better off with myomectomy. If you've got multiple fibroids, so it really comes down to patient desires. So I never guarantee, fertility. Women definitely can, and I've seen women get pregnant after Ufe, but you really have to have a good, discussion. Probably one of the bigger trials was done by a Dr. Pisco in 2017, who looked at women who got pregnant after fibroid embolization. They tended to be in their later childbearing years, so 35 and plus, so their fertility rates go down. And what he found within 2 years of fibroid embolization, about 40%. If you look, there was a recent paper that came out in 2022 that looked at every study out there that talked about fertility post-Ufe was as low as 20%, as high as 85%. So again, I think it just depends size, number, and location. So it varies. So yes, you can, but you really have to have a good discussion. Any woman who comes into me who requests fertility, I make sure they go and see a gynecologist, gynecologic surgeon, and infertility doctor. I want to make sure they get the full story so they make the most informed decision.
Absolutely. And that fertility specialist, they're taking blood, they're looking at numbers, they're giving you a whole picture, pre-surgery. And that is key as well, because whether you have the fibroids or not, if those numbers aren't what they should be, then that's a whole different obstacle to overcome. We have a question from Candace HC, who wants to know what makes someone a better candidate for open myomectomy versus laparoscopic if you're planning to get pregnant. I don't know who wants this one, Dr. Hawkins or Dr. Winter.
So we both perform both procedures, right? And a lot of the decision making as far as the candidacy and what your options are depend on both the size and location of the fibroids, your symptomatology, as well as things like your desire for fertility. Sometimes we make decisions also, well, not necessarily particularly for us, but a lot of gynecologists will also make decisions based on their skill set. What can they do, right? And that leads to even a deeper discussion about options, because myomectomy, hysterectomy are not your only two options. There are also others that potentially could be options, again, depending on the size, location, and some of your goals and desires, especially surrounding things like fertility. So usually the patients that have larger fibroids overall or larger uteri overall, the recommendation becomes an open myomectomy, mainly because we need space and the ability to see what we're doing laparoscopically to do a safe, and not just safe, but effective procedure. Because one of the things that you will read on your consent for a laparoscopic myomectomy is that potential to miss fibroids. And as we've already said, we know that there's a recurrence rate, and a lot of the recurrence rate is because fibroids are left behind by surgeons. So we also have to balance that risk when we make these recommendations to patients. Now, when you go see doctors like myself and Dr. Winter, who have been trained to do these laparoscopic surgeries to an even more complex state. I mean, I've removed 20, 25 fibroids laparoscopically in the past, and I use ultrasounds when I do robotic procedures as well. I use all types of modalities to try to help me not leave fibroids behind. But not every laparoscopic or robotic surgeon will do so. So it's a lot that goes into that question, but typically it's about the size, number, location, and then of course the patient's desire. But at the end of the day, it's actually the same procedure, and you have less risk when we can do it minimally invasive, less risk of adhesions, especially knowing that a lot of times we're making recommendations about cesarean section for patients post-myomectomy. That means that you can anticipate another surgery. So we want to go the most minimally invasive route, not just so you heal fast, but also to cut down risk of complications, blood loss, and things like adhesive disease.
Yeah. And I think that last part is key. I had an open myomectomy and I probably did too much too soon and my wound opened. And then, yes, I had a C-section for my daughter. With my son, I had a uterine rupture right along that scar. So the minimally invasive is something I wish, in hindsight, I wish that I would have looked into that more. We talk often about being an advocate for yourself. So Dr. Winter, just if you could kind of run down the questions that you want your patients to be asking you, or maybe the symptoms or the information that they should be bringing to you so that you can really get the best picture of how we can go about treating this.
That's a good question. So the most important thing in the history when patients come in is, are there symptoms, bleeding or pain? And with bleeding, we want to know, are your periods regular or they're irregular? How many days do you bleed for? At your heaviest flow, how often are you having to change a tampon or a pad? Have you ever been diagnosed with anemia, needed a blood transfusion or an iron infusion? So those are kind of my bleeding questions. Sometimes people sort of tend to minimize, right? So you can't say, are your periods normal? And people will say yes, even though they're like, carrying a bag of extra clothes in their car, so you have to like get into the specific, how long do they last for? How long are you changing? Or they'll say like, they had, oh, my periods are much better now, but they're still changing every hour. So you have to really ask those specifics. And then in terms of the bulk symptoms, those are the symptoms women have from fibroids just being in there taking up space. And a lot of times they don't know that urinary frequency can be related to fibroids, right? So you have to ask: pelvic pain, pressure, expanding abdomen, urinary frequency, constipation. Those are kind of my bulk symptom questions. And then the fertility piece. So do you want to get, is being pregnant something you might want to do in the future? That's how I phrase it. You don't have to know for sure, but if you might want to do it, then, hysterectomy is off the table. And then, have you been trying? Have you done assisted reproductive technologies? Are you working with an REI doctor? Do you already have embryos or not? So where are you kind of in that workup? And then, obviously you have to know their whole medical history, their prior surgeries, do they have any, complex medical problems? So
it sounds like you're with
the first visit takes a long time. I schedule my first visit for like 45 minutes.
Yeah, I do too. Intimacy. That's the only thing that I would.
Oh, yeah.
My questions are exactly, and in exactly the same order too. But then of course we also ask about intimacy. Is there discomfort with that? And is it positional and things like that?
Yeah, I think it's key because just listening to you go through that, I'm thinking, wow, you're in there for 45 minutes to an hour.
Yep.
And probably what a patient is expecting to come see you for, it might be, well, I think my periods are heavy. I didn't know that I had heavy periods because I had them my whole life and my mother had them my whole life. And then come to find out a normal period is like 2 or 3 days, and maybe you change a pad once or twice. And I'm like, say what now? Not me. So yeah, like really getting in there, the nitty gritty and kind of changing what we think is normal because it's just normal to us, is key. So I just want to make sure that everybody kind of understands what the advocacy is. And if you're getting in there with a doctor and it's 15, 20 minutes and it's rushed and it doesn't feel good, then, time to get that second opinion. Azalea has a question. She says, I'm scheduled for a hysteroscopic myomectomy. How new is this treatment and what is the recovery time?
It's not new. It's been around a long time. It's a procedure that's done for fibroids that are located within the lining of the uterus. So sort of inside the uterus where an IUD or a baby should be. It is really important for the doctors to figure out how much of that fibroid is actually inside the uterus versus how much of the fibroid is in the wall. Because I see a lot of people who went in for that procedure, the gynecologist got a regular ultrasound that said the fibroid was submucosal. They went in there, you shave it down from the inside, but you can't really dig into the wall of the uterus, right? You can just shave it down until the cavity looks normal. And sometimes they don't get the whole fibroid and they don't even know it. So, I have a little bit of a skewed perspective because I get all the failed hysteroscopic myomectomies that come to me that needing a laparoscopic myomectomy later. But it's really important that workup includes a saline infusion ultrasound, or an MRI, but the saline infusion ultrasound is the best. If the fibroid is more than 50% within the uterus, then there's a good chance you'll be able to get it all out. If it's less than 50% within the uterus, you have to be really skilled with a tool called a Receptoscope, which is something that most people aren't using anymore. Most people are using like a hysteroscopic morcellator that just shaves it down, but really can't dig into the wall. So it's a great procedure if you have a fibroid in the right location that can get the whole thing out. It's done as an outpatient. You go home the same day, pretty much back to normal by the next day. Your only longer term restrictions would be nothing in the vagina. So no tampons, no sex, no bathtubs for about a week because they're dilating your cervix, but like stairs, showers, everything else should be fine the next day.
Azalea, I do want to point out that both Dr. Winter and Dr. Hawkins made a face when I said that procedure. Maybe another opinion might be warranted. When we do these sessions a lot, and someone did bring up in our last session that you don't want to go out and get 8, 9, 10 opinions, because at that point you're just looking for someone to agree with what you want. But, 2 or 3, if you saw these 2 doctors here, they would have looked at you like, well,
I mean, I do them, but I just make sure I'm doing them in the right patients. And a lot of times
Yeah.
I'm doing them in conjunction with the laparoscopic myomectomy. So some of the fibroids are better got out from the inside and the rest are better to get out from the top. So I just see all the ones that didn't work.
Yes.
And it's important, just to add to that, it's important to that point, to be clear about that point, to know, are we just treating that one and I have several others and we're not going to be taking care of those? And what is the impact that the other fibroids might be having on my symptomatology? I'm not going to get rid of my urgency and waking up in the middle of the night and my pain with sex by just removing the one in the cavity. But for some patients, the heavy bleeding is what they're concerned about. And so they might actually get some significant improvement in that. Or it might take more of a combination procedure where we're both removing it hysteroscopically and then getting the other fibroids out, as best as possible, hopefully in a minimally invasive way as well.
Mm-hmm. Chasney Russell wants to know, is it common for fibroids to cause additional issues with the bladder, IBS, prolapse, and such? And Dr. Katashia, I know that you had IBS, and that's kind of what kicked off your health journey. Was that linked at all for you?
Constipation for sure. So with my issues, so in the beginning, just going into the doctor and discussing my GI issues, my provider never even linked it to the endometriosis or fibroids in my case. But once I went to my doctor and going deeper into my journey, that's when I learned the two were connected. Constipation for me when it came to my endo and fibroids.
And then Dr. Winter, Dr. Hawkins, Dr. Wolfe, is that what you all are seeing as well in terms of when you're asking about those bulk symptoms, any of the GI issues? Obviously, we know the frequent urination, any of those other issues that you see or hear about?
I see a lot of women misdiagnosed with IBS or interstitial cystitis who actually have endo. So when I think bowel symptoms, I usually think endo, although a large posterior fibroid can cause constipation and big fibroids can cause bloating. But if your problem is like cyclic bloating and pain with bowel movements, to me that says more endo than it says fibroids. And it's in patients with fibroids that we get surprised with endo the most, because we think we have an explanation for their symptoms, because there is a lot of overlap. And then we get in there, we're like, oh no, there's both. Great. So yeah.
Dr. Wolfe, someone had a question about UFE again, and those particles that you said that you push through the arteries and into the fibroids and cut off the tree at the root. Are those particles permanent? Do they disintegrate? Do they come out? How does that work?
Yeah, they're permanent. There was one or two companies who are coming up with a temporary embolic agent. If you're over in Asia, they use sometimes a more temporary, something called gel foam. But here in the US, most physicians practicing are using something called embospheres or PVA, which are permanent embolic particles. They're on the, micrometers, about 500 to 700 micrometers, so very, very tiny, and they just get lodged in. So the only way you would really see them is on like a cross section, like path, like slide through the fibroid if you later on had surgery, but they can't go anywhere. They're inert. So I always tell my patients, think of it, you don't think second about having non-absorbable suture being put into you elsewhere in the body if you have different types of surgery. So we can kind of think of it along that line.
Dr. Hawkins and Dr. Winter, Jade Fuller wants to know, is it recommended to take Lupron to shrink fibroids prior to having a procedure? I would think that for you all skill set, shrinking a fibroid is not a priority.
You're spot on. As far as I'm concerned, I don't use Lupron often, especially when I'm doing myomectomies, because sometimes it's hit and miss. Sometimes it can make the procedure potentially more difficult because Lupron softens the fibroid and sometimes blurs the line of what we call the capsule of the fibroids. It doesn't make it as easy to peel it out. And that can happen all on its own. So we certainly, if at all possible, don't want to add agents that might make our procedure more difficult. And in making it more difficult means that I might not be able to find all of the fibroids, or I might encounter more bleeding looking for fibroids that are soft, and I just can't get that distinction, that firmness that most fibroids have. Now, I don't use it often. We do quite large hysterectomies. I'll do a hysterectomy robotically up to about 30 centimeters or so. And I know Dr. Winter will as well. So it doesn't really add that much benefit to our surgical procedures and skill set potentially. But I might think about it for a patient that's having a hysterectomy, and getting a little bit more space might make the procedure safer. But Lupron has side effects. Right. So again, risk versus benefit for everything that we recommend to patients. And we have to consider that portion of it too. We don't want to make our patient miserable in the process. So that's my opinion on Lupron.
Yeah, that makes absolute sense. We have some questions about some other treatments, the Sonata treatment and the Acessa treatment. Can either of you all speak to those and kind of what those are and how they differ, and who would be a good candidate for those treatments? Dr. Winter, I saw that eyebrow right here.
I have not been trained on Acessa, but I'm about to start that journey. But I want to hear what Dr. Hawkins has to say, because I know she's a big advocate of this.
Yeah, so I do Acessa and Sonata. For complete transparency, I'm a speaker for Hologic, who has acquired Acessa in the last few years, but I've been with Acessa since it was a startup company. And what Acessa and Sonata, both of them are radiofrequency ablation procedures to which we're heating up the fibroids through needle tips and actually killing and denaturing the cells of the fibroid so that the fibroids shrink. Just like UFE, they're getting a shrinkage, which is going to improve their symptomatology of heavy bleeding and a lot of times their bulk symptoms. The difference between the two is that with Acessa, we do it laparoscopically, meaning we put a camera in the abdomen and then an ultrasound, which is the hallmark and the most beautiful thing about this procedure, because we just talked about how fibroids can be missed. So you put an ultrasound in the abdomen as well to help you find each and every single fibroid. And we can treat fibroids that are even 1 centimeter in size, because that 1 centimeter can be 10 centimeter in 10 years, right? And it is a minimally invasive approach, outpatient procedure. I usually tell my patients to take it easy for a week. They can be back to exercise in the time period after, maybe 2 weeks, back to exercise activity and intercourse. And then with Sonata, it's even less invasive. It's done hysteroscopically. So we're putting a camera through the cervix, no incisions on the abdomen, and we're doing the same thing. We're using an ultrasound to locate all of those fibroids that are in the muscle of the uterus. Because if it's in a cavity, we already learned we're going to resect those. We're going to take those out. But when they're in the muscle of the uterus, but not on the outside, right? Not on the skin of the uterus or in the abdomen, like a pedunculated fibroid, we're able to hysteroscopically through the cervix, put that same needle in, heat up the fibroid tissue so that they can shrink. And those patients still go home and they're back to life even faster, similar to that resectoscopic one Dr. Winter was talking about earlier, within days. So good candidates for those procedures, again, location and size. That's what it's all about. Usually we want to catch patients earlier in their disease process. We're not going to just go around treating every fibroid because not every fibroid is symptomatic and needs to be treated. But they usually get to our office and start to have this conversation because they want to do something. And so it's a lovely option to be able to treat fibroids earlier in a less invasive way that may not have as much long-term impact as far as potential complications and side effects, but also just, open up the doors of a faster, quicker, and less miserable recovery for all intents and purposes. We love these options.
Yeah. Now, how do those impact fertility, or do they?
Yeah, so both of those are not FDA approved to be offered to patients with the desired fertility. I can say off the record, I've given that statement, that even theoretically, we're waiting on the research. The reason that we can't get that stamp of approval is because we're collecting data. We're collecting data on patients who've gotten pregnant after these procedures and have had wonderful and successful pregnancies. So I counsel my patients just as such. I talk to them about that risk, what we do know, what the research has shown, the real world data. As a community physician, I can do that. And it depends. It depends on where those fibroids are located. Sometimes it's better to remove them. And then sometimes I've had patients, even in their fertility journey with REI doctors, that have sent me specifically for radiofrequency ablation, maybe because their fibroid needs to be taken care of, but actually isn't in the cavity, or they feel like they've had a previous myomectomy and we don't want to cut into the muscle again. And this is a better approach for that patient. So no cookie cutter explanation or answer for that. It really depends from patient to patient what that best option is going to be, even when it comes to fertility.
They're just from a research standpoint, and I can't tell you the exact numbers. Sonata just did come out with a paper a few months ago on some preliminary fertility results after their procedure, and it looked really, really promising. Assessa has not produced a paper, but like I said, I have it actually stored on my computer. I started reading it the other day, but I can't tell you the exact numbers, but Sonata does look really promising. As an interventional radiologist, again, this is off record, but I also do agree. I think that technology is going to be best served in women who have minimal disease burden in bad locations for fertility, that you really want to target the fibroids that may be impacting their fertility or future fertility. Again, I'm an interventionalist, but we've used radiofrequency ablation to cook tumors everywhere else in the body my whole entire career. In medical school, I did research on RF. So I do think it's going to be a great technology. And I think specifically in those women who are looking for future fertility.
And we just wrapped a large research trial for Assessa called an Ultra study. Literally, I just enrolled our last patient, and it's a national study. So we should have data out soon.
Good. Now, you both kind of touched on this next question, but I want to make sure that, it's clear. Candace wants to know, if you are planning to get pregnant, is it typical to remove all fibroids, or just the ones that may be impacting fertility, especially considering recurrence risk? And so again, I'll just offer part of my story. I had fibroids kind of all over, pedunculated and inside, outside, wherever else. And my doctor was, of course, concerned with the ones on the inside because you want an embryo to implant. But she also said, I don't want to leave anything behind because they're going to get bigger unless you have another treatment. And why continue to deal with this issue? So she removed, all of my fibroids, all 10 of them, the pedunculated ones inside, outside. And I believe I have one small fibroid making its way back on the inside of my uterus, but it's not causing me any issues at the moment. So that's just my take, my experience. But Dr. Winter, what would you say about that?
It depends on their symptoms. So most of the time, patients are also having symptoms in addition to wanting to get pregnant. In general, when I'm doing a myomectomy, I usually take out every single fibroid I can see or feel because we're already in there. They could grow, right? But occasionally, somebody, if they have an intramural fibroid that's in the wall, not affecting their fertility, and it's relatively small, I don't think it's causing symptoms. And going in there to get that one will mean that she has to have a C-section for future deliveries versus if I just take out the one that's in the cavity hysteroscopically or a more superficial laparoscopic one, she won't. Then I'll leave that. That's the one situation where I would recommend leaving it in place. If I don't think it's causing symptoms, and that would be the make or break for needing the C-section in the future.
I'll add, because I do ASESA, right, that thank God for technology and advancements. This is one of the places where I 100% agree, but I also might now be able to offer the patient, let's take the one out resectoscopically and let's ASESA the one in the muscle that potentially could grow during pregnancy and cause issues and problems and pain and increase your risk of preterm labor and preterm delivery, right? Because fibroids can affect the way that we also carry pregnancy, not just getting pregnant and holding the pregnancy, but how our pregnancy outcomes look. Now we have for patients more options to address that. And the studies that have been published in the Green Journal, it looked at outcomes of pregnancy with the ASESA patients, and half of those patients delivered vaginally. So we're also seeing that with this technology, we're able to potentially keep patients in candidacy for vaginal deliveries, even after treating their fibroids. So more to come, obviously, but that's the beauty of the advancement of this technology.
So we are getting somewhere thanks to technology, and maybe the research will eventually catch up so that we can have the prevention of fibroids. Wendy Payne has an interesting question. Is there a definitive way to determine if fibroids are malignant other than surgically? That typically fibroids are benign tumors. However, again, I'll share part of my story. I luckily had switched insurance with my jobs, and I went to one gynecologist 1 year and I went to another one the very next year. And within that year, I had a fibroid that had enlarged my uterus to the point where the doctor said, this is not in your chart the year before. I am concerned it could be cancerous or malignant, and I want you to go get an ultrasound immediately and go from there. So it was not malignant, but that was kind of my experience. But is there a way to determine if a fibroid is malignant other than surgery?
So we used to think that a rapidly growing fibroid was a risk factor for cancerous fibroid, but that turns out not to be the case. So I see this sometimes where patients have had a fibroid increase in size on imaging, and their regular OBGYN said, has to come out. We're worried it's cancer. And they show up to my office. They're actually not having any symptoms. And I get to be the bearer of the good news, which is like, well, it's not benign fibroids can grow rapidly as well. So that's a misconception that we should be stamping out aggressively. Because if we think something's cancerous, a lot of times that also limits our ability to take it out minimally invasively. So we want to really make sure we disseminate that information. Unfortunately, there's no way to biopsy fibroids, which is what you would need to prove it's not cancerous. So no, there's no way to definitively say that a fibroid is not cancerous. Without removing it surgically and having the pathologist look at it underneath the microscope. The only exception to that is that if a patient has fibroids that are intracavitary, I always get an endometrial biopsy prior to these surgeries, because an endometrial biopsy, which is just a little procedure done in the office, it kind of feels like you're getting a pap smear and then there's an extra cramp, that will pick up a cancerous fibroid 50 to 70% of the time. So not a perfect test, but the best test that we have. So if I'm going to be morcellating the fibroid, which means removing it in pieces, which is what we have to do to take big fibroids out of tiny incisions, I always get that biopsy ahead of time because it's the best test that we have. If I can't get that biopsy in the office, then I do it in the operating room in a DNC procedure. And if I'm in there with the camera and I see a fibroid that's just sitting inside the uterus, then I'll take that fibroid out that way and get the sample that way. So that tells us that that fibroid is not cancerous. It doesn't tell us that the other fibroids aren't cancerous. So that was a long answer, but hopefully that makes sense.
Understood. My takeaway was you can't tell if a fibroid is cancerous outside of surgery.
Nope. Correct.
Okay.
That's a great summary.
Good. Okay. Listen, I normally have a really hard time with timing these out because there's always such good information and so many questions. And I'm just so grateful that the White Dress Project has these periodically, just to make sure that we can all kind of regroup and get the latest information in terms of research and treatment options. Always good to have our patient advocates. Dr. Katashia, thank you so much for being here. Dr. Hawkins, Dr. Winter, Dr. Wolfe, thank you so much for sharing your expertise. I always joke and say you guys are here sharing your expertise for free. No one is billing your insurance. There are no copays. So we certainly appreciate your time because that expertise and insight is, valuable and it is worth something. So we certainly appreciate it. I would like for the four of you to just kind of give closing remarks, what you want the people here listening tonight to know, whether it's here's what you should have, when you go to your doctor, here's how your doctor should be responding to you. If you're having these symptoms, this is something to look into. Just what would you want people to take away from this, especially when it comes to advocating for themselves? Dr. Hawkins, I'll start with you.
Be your best advocate. I think I give the same closing remark every single time because I cannot say it enough. Speak up, give your symptoms, tell your story, explain your journey. Because sometimes if I don't know, there's not much I can do with it. Thank God that I also will pull from patients and ask a lot of questions. And hopefully I'll get you there. But it's so important to feel heard. And it does feel good to feel validated by your doctor that your symptoms are real and there's something going on that needs to be addressed. If you don't feel that way, get a second opinion.
Yeah, I always say if you go to a hairstylist and they botch your haircut, you're not going back. Dr. Katashia, I'll ask you, being that you are a patient advocate, what do you counsel women in terms of going to the doctor?
I mean, what I've been through and where I am now, just like Dr. Hawkins, I always tell my clients, my patients in the hospital, be the best advocate for yourself. You are not being a difficult patient. You are advocating for yourself. So prepare yourself emotionally, mentally, and physically for this ride, because most definitely you would need it. You need the village beside you and to get you to not just the end, but every spot on that journey. You need someone, you need someone with you every step of the way. So just know that you are not being difficult. You are most definitely putting yourself first, and speak up and be bold in your words.
And I would, add to that, again, in the Black community, we don't do a lot of talking about periods and bleeding and fibroids. And I had fibroids, and then come to find out my mom says, oh yeah, I had those. And I'm like, well, you could have let me know. Maybe I would have had a clue. So also finding someone who's been on that journey and having them be your buddy to walk you through. Cause there's going to be days you're going to have good days and bad days. So thank you, Dr. Katashia, for your insight. Dr. Wolfe, the takeaways that you want people to know from tonight and here forward.
Sorry, it cut out briefly, so I couldn't hear.
Just the takeaways that you want, the advice that you would have for those listening in terms of advocating for themselves.
Yeah. So, I mean, first of all, it takes a village. So have a very comprehensive, supportive team. Make sure you get opinions from everyone, including your gynecologist, mental health workers, people who can go the holistic approach with dietary needs, your interventional radiologist. I think women get the best care when we work collaboratively as a team, and then use outside resources. So again, I'm with the White Dress Project. I think the White Dress Project is an incredible advocacy group that has multiple resources. With the Empowered Patient Brunch, we will be having, the Empowered Patient Experience again next year. On the website, we have a patient toolkit that you can download and actually arm yourself with information, questions when you go see your provider. So I think knowledge is powerful, and especially when it comes to women's health.
And I will piggyback off of that, because the White Dress Project is a major key, a major resource, and it beats going down the Google vortex and talking to people who've been to Google University and getting all kinds of misinformation and scaring yourself. So if you can go to the White Dress Project, which is vetted information, that'll save you a lot of heartache and time. Dr. Winter, you're the last one to go.
I think it's important for women to surround themselves with a team, like Dr. Wolfe was saying. So if fertility is an objective, consider bringing in a fertility specialist. And then I always like to tell people that, whether or not a fibroid can be removed minimally invasively, or whether or not you're a candidate for a fertility sparing surgery, has almost nothing to do with what's going on inside of you, and almost everything to do with the skill level of the surgeon. So general OBGYNs who do everything, they deliver babies, they do routine care, they also operate, and some operate quite a bit, but some operate very infrequently. So minimally invasive gynecologic surgeons like myself and Dr. Hawkins did 2 years of additional training after their regular OBGYN training. And then ever since, we've been in practice, I think the same for you, Dr. Hawkins, never delivered babies, don't do routine care, only see patients for surgery. So there's a really big difference in the skill and the surgical volume. And I don't think women understand that. I think that's really important to know. Not everybody with fibroids needs surgery. So you don't, maybe don't see the surgeon as your first stop. But if you're considering surgery, I would strongly think about seeking out a surgical subspecialist.
Surgical subspecialist. Okay, Dr. Winter with all the gems tonight. Thank you so much. I am done here for tonight. It is always a pleasure to be here to host these, to talk to the experts, and to disseminate this information. I always want to thank the White Dress Project and Tanika Gray-Valbrun, who is here, for inviting me. And I'm going to toss it over to you now, and Kim, who coordinates and organizes these and brings together these experts and these amazing panels and thinks out the topics. So, and Kim, you're up, my friend.
Thank you, Adriana, and thank you, everyone. Thank you, all the panelists. Dr. Katashia, I'm always so amazed to hear your story, and I appreciate you for always walking boldly, courageously, and confidently in your truth and giving us all the gift of your story. It's empowering, it's impactful, and we appreciate you so much. So thank you so much for being a part of the White Dress Project family. And to all the doctors, Dr. Hawkins, Dr. Winter, Dr. Wolfe, someone mentioned in the chat that, it's hard to find doctors that you can trust. So thank you all for being, or reinforcing for all of us, that there are good doctors out there like you. It gives us all hope. That this journey is not hopeless, that, there are doctors out there that truly, genuinely care about their patients, want to see us thrive, want to see us succeed, want to see us, reach our health goals. So thank you so much for the expertise that you provided. Thank you so much for taking the time out of your busy schedules to be here with us. You all are part of the White Dress Project family, and we appreciate you so much. And Adriana, thank you always for your support, for moderating these discussions. We could not do this without you. So thank you, thank you, thank you. And to Nikki behind the scenes, providing the technical support. We appreciate you all. And for everybody who is here in attendance, we hope that, this was informative for you, that this was insightful. We will continue to have, sessions like these. We'll continue to have these discussions to keep you informed, to keep you empowered, to keep you educated. We do have a couple more sessions for the month as part of our 5-part virtual series. The next one is next week on the 17th. That will be taking place on Zoom as well. And it's going to focus on fibroids and stress. So you can sign up at the link in our bio on our website. So thank you all so much. And we hope to see you at our future sessions. Tanika, I don't know if you have anything to say.
Good evening, everyone. I'm so sorry I'm not able to join on camera tonight, but Nkem said it best. We're so grateful for our panelists, so grateful for Adriana. All of you do this out the goodness of your heart, and we just want to thank you for imparting so much into our community. Thank you, everybody, for joining. Spread the word. Have a great night.
Thank you.